Good morning and welcome to our second panel discussion of the morning titled Implementing for Equity. We are really excited by the panelists we have here today. Our first panelist is Dr. Cynthia Owusu, who is an associate professor at Case Western Reserve University School of Medicine in the Department of Medicine and the Division of Hematology and Oncology. She is a breast oncologist as well as a geriatric oncologist at University Hospital's Seidman Cancer Center. In addition to her clinical practice, Dr. Owusu is an NIH-funded researcher whose work focuses on health outcomes and health disparities in breast cancer patients. She is Associate Director of Diversity, Equity, and Inclusion at Case Comprehensive Cancer Center and the Faculty Lead of Health Disparities for the Clinical and Translational Science Collaboration of Northern Ohio, all of which align with her passion for breast cancer health disparities research. We also have with us today Dr. Peter Hovmand, who is the Pamela B. Davis MD, PhD Professor of Medicine with joint appointments in the Center for Community Health Integration, School of Medicine, and the Department of Biomedical Engineering in the Case School of Engineering at Case Western Reserve University. Dr. Hovmand's research focuses on advancing methods for engaging communities and organizations and understanding the system dynamics of translation and implementation of innovations for advancing health and health equity. We also have with us today Dr. Jarrod Dalton, who is the Director of the Center for Populations Health Research and Associate Staff within the Department of Quantitative Health Sciences at Cleveland Clinic. He is also Associate Professor in the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. Dr. Dalton's training is in epidemiology and biostatistics, and he has worked collaboratively across CTSC institutions on NIH-funded research and health services and health disparities research since 2013, particularly in the area of neighborhood health disparities research. His latest project, funded by the National Institute on Aging and in collaboration with Metro Health, involves stakeholder-driven approaches towards neighborhood health improvement. Here, his team is using synthetic population or digital twin simulation modeling methods to project the impact of population health interventions on individual communities. And finally, we have Dr. Sanjay Ragopolan, who is the Chief of Cardiovascular Medicine, Chief Academic and Scientific Officer at University Hospital's Harrington Heart and Vascular Institute, the Herman Hellerstein MD Professor of Cardiovascular Research, and the Director of the Case Cardiovascular Research Institute at Case Western Reserve School of Medicine. He has led many innovative initiatives in healthcare centered around innovative care delivery for high-risk patient populations, precision medicine initiatives, and next-generation approaches for the prevention of heart and metabolic disease. Dr. Ragopolan is the recipient of the American College of Cardiology's Distinguished Scientist Award. He has been funded continuously through the NIH and currently holds a prestigious 8-year R35 Pioneer Grant. So we are thrilled to have this esteemed panel with us today. And we would like to kick things off by just having each of our panelists speak for about 5 minutes about your current role in the work that you are doing. And we will start with Dr. Owusu.
Good morning to everybody. I am excited to be here and to have an opportunity to contribute to this very important discussion. Thank you for that wonderful introduction. And as the introduction said, some of my work focuses on health outcomes, specifically functional health outcomes, and reducing functional health disparities among breast cancer survivors. In that particular work, which was funded by the National Institute of Minority and Health Disparities, what we did was to design a randomized controlled trial, an exercise trial, for older women who had just completed treatment. I like to focus on the areas where we did apply some of the strategies in implementation science. So before we actually rolled out the randomized controlled trial, we adapted a mixed methods approach and enrolled 60 women who had the same eligibility criteria as the patients we were going to recruit into the exercise trial. And with these 60 women, what we focused on was to examine their attitude and perspective towards exercise, particularly what their preferences were regarding how an exercise intervention should look like and what they would find acceptable. So that went on for about 6 months in the first year of the study. And drawing from their preferences, we used that to design the exercise intervention. And that was very beneficial because we found that adherence to the intervention was very high. They told us that some of their preferences that we adopted readily was they didn't want an individualized exercise program. They wanted a group exercise program. So we very quickly changed our intervention into a group exercise program, which fostered a lot of belonging within the group and ensured that they adhered to the protocol. One of the interesting things was they wanted, specifically, majority wanted a mid-morning exercise program, which I would never have thought of. And their rationale was, well, they can come in mid-morning, exercise, and after that, go together with everyone and have lunch. And they really wanted to avoid traveling later in the evening as it could get dark. Well, so in a nutshell, using an approach of stakeholder engagement before even designing the exercise intervention, we saw that it really ensured adherence, acceptability. At the end of the exercise intervention, we also did an exit interview, trying to garner from the women what worked and what didn't work. And we're using that to design a second version, an improved version of our first intervention. So this is one example of the work that I do that I wanted to share with you.
Thank you so much. Dr. Hovmand, you can go next.
Yeah, thank you. And I've so far really enjoyed the conversations throughout the whole morning. It's really been fantastic. So a lot of my work really begins with thinking about systems. We talked a lot about understanding systems and the context of systems and actually getting at some of the causal mechanisms. And that involves, for me, using system dynamics and sort of engaging communities, stakeholders, different organizations, and thinking about how they implement or is planning to implement a given initiative. And in terms of thinking about that, and then it's particularly where my interests overlap is with the topic of equity, is thinking most of the inequities we see in systems, I would argue they involve essentially an implementation problem. Either it's not scaling, or it's not reaching, people, population of interest at the same speed as everybody else. So specifically with respect to implementation outcomes, things like scale up, reach, and sustainability. And it could, the sustainability pieces, we touch on that a little bit today, but in system dynamics in my field that I work in, that becomes a common issue. You could have early wins and begin to scale up things, and then you get increased demand. And then the feedback dynamics make it really hard to sustain it. We talked about some of the pressures that clinicians are facing today, for example. the application areas have been pretty broad, also include global health. And I think where implementation science really sort of became much more directly of interest with respect to equity was in some work initially with Gates Foundation. Gates was looking at scaling up public health interventions, and these typically they weren't associated with a product or a pharmaceutical. It was breastfeeding, or it was water and sanitation, or it would be there was a whole sort of array of interventions they were trying to think about, but not achieving reach. And Melinda Gates gave a talk at that point and said, sort of, how come I can get a Coca-Cola anywhere in the world, but I can't find condoms, for example. So I was involved in some work where we're starting to do that. And anything about implementation is an inherently dynamic process. It evolves over time. And in asking folks about how they were picturing what the barriers were and why we weren't achieving reach, it very quickly became apparent there's a variety of ways we could be facing that problem. It could be we can't accelerate the S-curve, we can't even get things off the ground, we can't achieve sufficient reach, we can't sustain it. Then the other sort of example that jumps out is some work with Implementation Science Network through Fogarty at NIH, and looking at clean cook stoves in particular. And the result there that sort of really jumped out was where in Gates Foundation an 80% reach might be considered the goal. Some of that work on ambient air pollution and household air pollution was showing that you need to get to 95% reach in order to be able to see the population level benefits. And that for me sort of changed how we were thinking about the problem, just from doing community work and in global health space. Because that last 20% is going to be typically the hardest to reach, and that's going to overlap with the most marginalized communities, and where there will be many sort of that contextual dimension becomes much more critical. So I'm thrilled to be a part of the panel, and also some of the projects Sarah Ronas. She mentioned some of the work we're doing around implementation strategies and using community engagement, system dynamics in particular, to think about that, and optimistic that there's a tremendous set of opportunities here for, in particular, advancing health equity.
Dr. Dalton, we'll hand it over to you.
Thank you, and good morning, everybody. And I'll echo those sentiments. It's been an amazing symposium so far, and I'm really honored to be a part of it. As Dr. Chep mentioned in the introduction, our work is really focused on understanding neighborhood health disparities, and that work has generally fallen into two buckets. The first one was measurement studies that we do to refine our understanding of neighborhood environments, collecting place-based information and trying to organize it in a way that is meaningful and interpretable. And the other big bucket there has been epidemiological studies, and we've used integrated electronic health record data across Cleveland Clinic and Metro Health System in Northeast Ohio, and we've applied it in different ways to understand patterns of health status, care, and outcomes across small areas in the region. And more recently, we've added a complementary line of activity through a joint study that, as you mentioned, was funded through the National Institute on Aging, which we call Digital Twin Neighborhoods, or DTNs. And really, this work is motivated by our consistent findings, as well as those of other groups, of stark neighborhood health disparities, disparities in health outcomes across neighborhoods in Northeast Ohio. I mean, at this point, the 25-year disparity in life expectancy among neighborhoods within Cuyahoga County, just a mile and a half away from one another, is pretty well established. But I guess, drawing from this theory of fundamental causes, we're really interested in learning why these disparities persist despite the best efforts of our healthcare providing organizations to provide timely and high quality care. Now, certainly access and prevention is a big piece of that, but we also acknowledge that the ability of care providers in a one-on-one patient care setting to impact these complex patterns and health outcomes across communities is very limited. And that we really need to go above that, ecologically speaking, and strategize interventions and implementation strategies that directly care for the health of neighborhoods. So to do that, we kind of recognize the need to be able to reproduce the mechanisms, as Dr. Hovmand was mentioning. So there's this idea behind system science and really trying to reproduce mechanisms that drive disparities. Because really, how do we design and implement effective interventions if we don't understand the underlying mechanisms? So on the research side of things, we're developing agent-based simulation models that capture life course trajectories in chronic disease development and preventive care utilization. And what we do with those models is we apply them to synthetic neighborhood populations and study how well. So on the research side, we do this thing called calibration analysis, where we study how well our population-based simulation is able to reproduce what we're seeing across neighborhoods in Northeast Ohio. And, so all of this is research. We're not even in the pre-implementation stage, but we are beginning to study the effects of hypothetical neighborhood level interventions. And I think this is what can be potentially valuable as we design interventions. As a part of this, we've conducted community engagement studios to understand from community members their preferences and concerns regarding this synthetic populations approach, so that we can inclusively and ethically align our work with the priorities of communities. And we heard concerns about biases and accuracies of health data, that our interpretations of what we consider to be optimal or desirable health outcomes may differ from that of community members, and that there's a need for us to routinely work with communities so we can identify so we can hear from them and work together to identify problems that are relevant. Moreover, so that we can co-design our research approaches and ultimately disseminate our results and get iterative feedback in partnership with these representatives and organizations. So again, this doesn't really fall under implementation, but I do think the value of our approach is that it provides a way of sharing representative data on neighborhood health outcomes with community organizations and residents. Obviously, as healthcare organizations, we're challenged by privacy of data and issues around protection. And through this synthetic population approach, we hope that, and our goal, our activities are oriented around designing interventions and implementation strategies in a way that may ultimately be more effective. And again, I'm grateful to be here today to share experiences and begin to incorporate the approaches that we're hearing about today into our work.
Great. Thank you very much. And next we'll hear from Dr. Ragopolan.
Thank you so much. It's a pleasure to join this panel and be part of this group of individuals. And I was tuning into the last session and was truly impressed with some of the speakers as well as information provided. My background as a cardiologist really has allowed sort of a tapestry of experiences. And the first observation is that there are, huge problems from cardiovascular inequities and delivery of healthcare to bring solutions that really work in people. So we've been very good over the last 3 decades in doing randomized controlled clinical trials and saying that one drug works for cholesterol or hypertension, but we've not done very well in terms of translating some of those discoveries into implementation strategies that work, right? So some of my observations have been and work in this area has been motivated by the fact that we need to do better in terms of understanding how we can bring these strategies, particularly to populations that need them the most. The second sort of component of my connection with health equity and implementation is really the observation that cardiovascular health, which is a leading cause of global morbidity and mortality, is driven more by the environment that you live in than genetic factors, right? 90% of health risk attributable to heart disease really comes from the environment. And that's the physical environment, it's the social environment, it's the built environment. All of these factors play an inordinate role in determining health outcomes, particularly in communities that most need it, right? So this fascination with the determinants of environmental determinants of healthcare have really taken on an especially important significance for me, because now with the intersection of environmental factors and climate hazards, particularly as it pertains to the oft-quoted observation that the communities that are most likely to be impacted are indigent communities, where we have a desperate need for better strategies to implement what we know to improve health. But that also brings about a different problem, which is most of the problems that we associate with the environment are negative externalities of the cost of doing business, and the society that we live in. Problems like air pollution, et cetera, that inordinately determine health outcomes, but for which the costs are sort of, essentially spread out. And the person polluting or causing the problem in the first place is not held accountable for those costs. So the negative externalities of what we do as a society, brings really some important questions to consider. How are we going to deal with this? When we talk about inequities in healthcare in Cleveland, and Jarrod talks about the massive difference in life expectancy between that one neighborhood versus the other. It has a lot to do with the environment. It has a lot to do with the implementation of what we know to these populations. But the problem is some of the costs associated with this are not felt by the people that are responsible for it. So that really has taken on an important meaning to me, because it's a convergence of a healthy environment, a healthy society, with all the essential attributes that you need to provide care that's going to determine healthier outcomes for people. Specific to this project, and I'll just comment on the previous speaker, maybe this will get the conversation going. My project that I'm working on right now, one of the projects is to apply precision health approaches, inexpensive precision health approaches that can improve community disparities in health, in particular as it relates to cardiometabolic outcomes. And there's a huge problem of implementation to bringing better approaches for hypertension care or metabolic care, obesity care to Black communities, because these are communities that can't afford the medications. They don't have access to some of these medicines. And more importantly, they may not have access to healthcare. And again, they are right in the maelstrom of multiple environmental and social influences that just completely decimate any possible health outcome from a cardiometabolic perspective. So how do you do this? How do you develop better models? Okay, how do you implement better models that can improve health outcomes in communities that most need it, who are the convergence of multiple environmental influences is sort of the topic in Achieve Greater. And we're sort of exploring community health worker models that can potentially serve the last mile problem for healthcare in populations that need it, testing new models of delivery, testing new models of remote monitoring that can provide better awareness for these patients, et cetera. But following a community first approach. Right. And I was recently very pleased to see, I think, an article that came out, I believe either in the Lancet or JAMA, I can't remember where they talked about global health and sort of this approach to global health, which has dominated our consciousness for many, many decades now, which is a top-down approach where somebody from a Western country comes and talks to somebody in India, Nigeria about, health. And it's completely the opposite of what you want. You want global health to be completely driven by the communities and the contextual circumstances of the problems that they are facing. And it's very similar to inequities in North America, where solutions need to be driven by local communities. And folks, individuals, many of us in this discussion today really should listen and try to develop strategies that are context aware and take into account the feelings and thought processes of the communities that you're trying to solve these problems with. So anyway, thank you, and delighted to be here.
Thank you so much. I'm honored to be even part of being moderating this panel, because you're having such accomplished individuals on this panel with such incredible insights about the problems that we face with health equity is incredible. After hearing all of you speak, I mean, the importance of stakeholders, understanding that on an individual level with Dr. Owusu's project, or just on a systems level with, I think, all of the rest of the panel's comments, I think that we all kind of listen and we're in agreement and we say, yes, like we need to change this, right? And so then my question is, what are the barriers? Why are we not able to do this as effectively as we would like to do? And I guess thinking about our last speaker as well, in terms of measuring efficiencies, when I sit back and I think, okay, as a healthcare organization, for example, we think about efficiencies and we want to improve that, but that doesn't always align with also improving equity, because sometimes those are two separate goals. And so I am actually curious about the barriers that each of you have faced in even doing the incredible work that you're doing. So maybe we'll call on you individually. And Sanjay, you're on my screen, so I'll just have you answer that first, and then we'll go around.
Let me start off and sort of, try to connect this with the previous speaker, because I think that's important, right? Because he brought up, I think, some incredible, issues. And the first thing that he talked about was the information asymmetry problem, right? And, just the analogy of the restaurant business, which I thought was incredible. And I was in New York recently having a nice Italian meal, in a restaurant that I chose by menu pages. And I couldn't believe the extent to which customer service in New York City, in Manhattan, this was in the Lower West Side, was just incredible. There were just these guys just fawning over us, literally, and saying, is your meal good? Is this, can I do this? Can I get you your meal? If you don't like this, I'll switch your meal over. But that, brings to our consciousness the problem of just information symmetry, where everybody is so price aware in New York in menu pages because they can choose where they want to go to. And that's a perfect example, because in healthcare, we have massive information asymmetry still. But I don't know what the cost of doing stuff is anywhere. There's no transparency. There are all kinds of players in the background trying to have a gain out of something. And they've literally kept this whole system, the economics of healthcare, still very opaque, because I don't know. So until you solve the problem, and there are folks that deliberately try to undermine this because they don't want people to know, because there are so many people making commissions out of every aspect of healthcare. So that's a fundamental problem that needs to change. We haven't solved that, right? So the other issue is, just briefly, just for conversation, is sort of talked about two things: the productivity frontier, clearly, and where do organizations invest in as it pertains to implementation. And the issue is, how do you implement cost-effective models to solve inequities? And that's a huge problem, because who's paying for the negative externalities? It's not the hospital, right? I'm not paying for the trees or whatever, the environment and pavements and lack of restaurants in East Cleveland. Hospitals are not engaged in those conversations at all. So how are you going to solve, problems that you're not directly responsible for, or it's not in your books, right? That to me is a major, a problem. And the third thing he talked about is obviously the short-termerism, which exists in every healthcare organization, where I'm thinking about the next year. And many of the problems and inequities, to solve them, are long-term problems, right? That you can't sort of conjure up the math of the economics of it within a 5-year horizon. Mm-hmm. So anyway, I just thought I'd bring that up for conversation.
Thank you so much. Cynthia, we'd like to hear what you think.
Yes, thank you very much for that question. So what are the barriers that are preventing us from applying a health equity lens to implementation science? I think that intentionality is key. A lot of times we develop our interventions, we have an implementation plan in place. The last thing on our minds is health equity. And so we need to have that at the forefront. We need to be intentional about it, because if we are not, the very intention of having an implementation strategy to address health equity will actually exacerbate and widen the disparity. And so I would say that we all have to be intentional about it all the time. And we have to have, the way I think about it, I think there are five things that need to come to one's mind when thinking about the application of a health equity lens. The first thing, as I mentioned, and a number of people have mentioned that, is consideration for stakeholder involvement or community engagement, even before the design phase. Ensuring that the voices and perspectives of marginalized communities and underserved populations are involved. For example, what I didn't mention when I was talking about the exercise study is that we ensured that of the 60 women we invited for the focus group discussion, 30 of them, 50%, were African American or of lower socioeconomic status. And that is when we found out that transportation was going to be an issue, and we needed to provide transportation if the intervention was going to be feasible. The other thing is consideration of frameworks. There are frameworks that have been now adapted and designed to ensure that health equity is an integral part of that framework. These are the frameworks we should seek to use when coming up with an implementation strategy. And one example is the Re-Aim for Sustainability tool, which does that beautifully. You can also use your preferred framework, but then go back and adapt health equity considerations and approaches across the framework. The other thing is our evaluation measures. For instance, we must ensure that we have built into our measures that address health equity. Within, I mean, as part of the contextual factors, for instance, racism, are we, and when we say health equity, what's even the definition? How are we measuring that? And so these are all things that we need to go back and reflect on when we are implementing for health equity. And so in a nutshell, I think, yes, there are many barriers, but one of the main barriers are us, the researchers, because we are not being intentional about it. Thank you.
Thank you, Cynthia. Thank you so much. Peter.
Yeah, so in terms of the challenges, I think there have been great points sort of raised so far already. I think one of the things that sort of really jumps out is the difficulty of actually getting the incentives aligned around with the needs. And Sanjay was talking about this in terms of the negative externalities and who pays for it. And the problem is, in one sense, is that health equity is a public good, and we're not specifically paying for it. We do lose things, people losing time from work, all kinds of things that are happening at a societal level, employment level, where health equity, if it was available as a public good or improved, would be much better off. One of the fundamental differences between some of the earlier work in implementation science that focused more in industry, like manufacturing, and healthcare is that in a manufacturing system, so when quality chasm, the IOM report talked about in the quality chasm that was referred to earlier, talked about gains that had happened in manufacturing and how come we can't apply some of that in terms of quality improvement in healthcare. The incentives aren't aligned in the same way. And especially as we start thinking about things that are outside the healthcare system, and all the services and infrastructure, things that Jarrod and Sanjay have also talked about. And I think one of the things that's often missed there is going back to actually the early insights from quality management. We talked a little bit about resources and having investment and money to incentivize this and the researchers, but that wasn't the original, at least in Deming's work on quality improvement, that wasn't the original sort of insight. Original insight was actually how quality improvement could allow companies with limited resources to reinvest in continuous quality improvement and have higher profits in manufacturing. That type of virtuous reinforcing loop is the key to this, but it means actually engaging folks across multiple systems actors. So the patients, the community members, the family members who are driving the patients, the providers, and so forth. And some of the early work that I did in this space, looking at things like efficiency and effectiveness and trying to find those feedback loops, it wasn't that providers weren't willing to make an investment of whatever discretionary resource they had at the time. I remember one clinician saying, look, if I can spend, if this will get me 15 more minutes with my patient, I'll do whatever you want. The problem was it was often questionable how that investment in a particular research project or a change initiative or some implementation of a new form would actually do that. Often the concern was rightly that this would make their work less efficient. They would have another form, additional things like we did there. In that particular case, they're talking about forms. But I think through when we're engaging the communities and we have these partnerships and to bringing up Cynthia's point, I mean, that has to come from the beginning. So it's not just sort of going to a community and saying, we've got this idea and what do you think about it? It's actually building that relationship. Doug Bruce talked about it earlier in terms of now there's a partnership, community members are actively involved. And we have some work that's along those lines that's really exciting and in terms of thinking about working with community-based organizations and addressing lead poisoning in communities. And from a community perspective, in terms of the partners like Undivided Cleveland that we're working with, and CCOL, there's no problem thinking about these problems as implementation science at all with respect to structural racism and so forth. That's not the issue. And so I think there are exciting opportunities, but they have to build that relationship. They have to deal with the historic wrongs. They have to build trust over time. And then really involve organizations, community members in the very beginning of the conceptualization of what it is that we're trying to address on a particular topic. So I see a lot of excitement from community-based organizations and the folks that I work with on that. And then there is the challenge of whether or not it aligns with a particular researcher and goal and trajectory. That's a separate problem. But
thank you. Thank you so much. Jarrod, I want to make sure you have.
Sure. I'll make it quick. I can speak from only from the perspective of a researcher here. And as a researcher, I think one barrier that we often encounter is an assumption on our behalf or on the behalf of others that implementation is separate from science, as Dr. Aaron was talking about earlier this morning. And, that, you have an organizational role that's defined and characterized by research. And, we have other experts that are, really in a position to make decisions on implementation. And I think, maybe, that is where implementation science sits. And if we carry that idea more broadly, one barrier that I see is that, interventions to be effective need to be defined and identified across sectors. And how can researchers be a part of that conversation in meaningful ways? And we've begun to do that with some local organizations across Northeast Ohio and are helping to co-develop some strategies for improving neighborhood environments with them. But at the end of the day, one of the things we've seen in these collaborations is that there's a need to be responsive, from a data engineering perspective, from a getting results perspective. What are the current relationships we're seeing, like this quarter, this month? Not, we pulled a cohort from 2009 to 2017, and this is what we saw before COVID, right? That's not necessarily going to be responsive to the needs of organizations and decision-making organizations. So we need to learn how to be more adept and quicker with our analyses and be able to be responsive to questions by groups.
Thank you. Thank you so much.
We have about 5 minutes left, and maybe a good final question that you each can speak to harkens back to something Dr. Wagner was talking about efforts to find a health economist as a collaborator. I'm wondering if you each could maybe talk a little bit or say a few comments about any advice or tips you might have for someone who's listening today who wants to find a health equity collaborator for their implementation work. And Jarrod, we can start. We can start with anybody who.
I just want to make to close out the last conversation before I answer your question is, what Peter said, I think is, and what Jarrod also mentioned, I think is quite important in terms of aligning, the incentive models right now, which are completely misaligned. If you're trying to solve problems or implementation of strategies for solving health inequities, right? Completely misaligned. And that's a real fundamental issue, because unless you start to get healthcare organizations and hospitals to put in incentives to solve this problem, you can have all the right intentions and goodness in the world. You're not going to be able to do anything. So that's one problem. The second problem is a last mile issue, which again is sort of, connected to the first issue of aligning incentives, because there is a huge last mile problem of implementing strategies locally with local contextual information with communities that you're trying to and I'm speaking in particular about cardiometabolic problems like hypertension care, for instance, or obesity, where you need to pay a lot of emphasis on lifestyle improvement. There's some behavioral problems as well. There are access issues, and these can only be solved by people that are locally conversant with the contextual circumstances of the communities that you're trying to serve. So unless you get behind this in a way in which you can incentivize models, and they can talk about community health workers and stuff like that, but even those models are not currently rightly incentivized. So that's a real problem. To your question, I think what I've struggled with is, and I think the last speaker from Stanford, I think, put this in the right context, right? Most clinicians and folks trying to write a grant or write a grant on economic models of the intervention that they're trying to study have this somewhat wrong, because many of them want to do a decision node based analysis, right? Or incremental cost effectiveness, et cetera, which are good in academic journals. And increasingly everybody does it, whether you're talking about Markov models or, other types of approaches. And decision node issues are some things that I've found very difficult to recruit economists to, because they're not the right people to be doing that type of research. So you have to find somebody else, right? Who's that might be an operations research person or somebody who's familiar with these types of decision node models, where you know the cost of implementing a strategy, and you can come up with some economic models, financial models, right? But the larger, more important questions in terms of efficiency, productivity, and financial budget impact analysis might go way beyond some of these more simpler models. So when I've tried to recruit economists, it's been difficult, challenging to get the right person in your. It's my sort of experiences. I've gravitated towards people who do this sort of work, and many of them are not economists, actually, right? But I've really, to be honest with you, I haven't really looked at the microscopic granular details of economics of implementation, specifically looking at time activity analysis of folks working on an intervention. So I must claim I don't have any experience in that area. So thank you.
Thank you very much. Do any others have thoughts on, if somebody who's listening who wants to collaborate with a health equity scholar or researcher, particularly given what we said about having intentionality in your project? Do you have any tips for anybody who might want to collaborate with a health equity researcher?
I guess I have two suggestions. One is sort of a broader point, which is I think often, and Dr. Regner touched about this, like what's an interesting question to an economist, right? So we might think of a question that's of interest to us because we're trying to write a grant or paper, but it's not an interesting question to that particular field. So one aspect of that I think is really doing a little bit of homework and reading up, whether it's economics or if I'm reaching out to an engineer, trying to understand what's the current problems that are of interest. And the same thing I think also goes true for health equity, like have an interesting question, do a little bit of homework. But the other part I would add is not necessarily to rely on our existing professionalized networks. Our professionalized networks are building in a certain patterns of socialization into expectations. And I think there's a tremendous opportunity to think about collaborators with as community members, folks who are not necessarily in a professionalized network or outsider networks. And that starts from, it's more of a random walk and getting to know organizations, communities, going to events. And I found that to be incredibly helpful.
Great. Well, thank you.
I also wanted to mention that I also think that one of the barriers to actually implementing with a focus on health equity is simply the lack of experts in this field, which makes it difficult, very difficult for researchers, even if they know that having an implementation scientist on board as a collaborator is very important. They really are not able to find anybody to join their team. And in that regard, I want to mention a project in its very infancy stage, building up within the CTSC. And Jarrod and I, plus 3 other investigators, are part of this team. And what we are looking at is a tool called Amy. And it's developing an artificial intelligence tool to improve health equity in implementation science. And the whole idea is to use an AI tool to help researchers once they have a proposal, assuming they don't even have an implementation plan in it, to feed the AI tool with the proposal, and then the AI tool then comes up with an implementation science strategy that applies a health equity lens. Or even if you have a proposal that previously had an implementation science strategy laid out, the tool could look at it and see whether there are any gaps to fill or to close up. It's very much in its infancy stage. It is it's based on, it's using the Re-Aim for Sustainability framework to develop the AI's capabilities. And so, and we think that would be very helpful as an initial strategy. Doesn't mean that you shouldn't have an implementation scientist on your team, but it will go a long way to ensure that right from the beginning, you are engaging the appropriate strategies to ensure that your implementation strategy is robust.
Great, thank you. Thanks for sharing that. And that closes out our panel for this session, and we will move on to our final session for the morning.